Hello everyone, welcome. In this topic, we are learning about sickle cell disease. The outline of discussion is introduction, sickle cell disease spectrum, genetics and pathophysiology, laboratory investigation, clinical features and syndromes, specific therapy, screening program, and summary. Introduction. Sickle cell disease is a multi-system disorder. Three-quarters of the total sickle cell disease cases of world occur in Africa. In India, the sickle cell disease is distributed geographically in central and the western regions. The prevalence of sickle cell gene is as high as 5% to 34% in various scheduled tribes. Sickle cell anemia is inherited disorder of globin chain that causes hemolysis and chronic organ damage. Sickle cell anemia is most common form of sickle cell disease with a lifelong affliction of hemolytic anemia requiring blood transfusion, pain crisis and organ damage. Sickle cell disease spectrum is composed of but not limited to sickle cell anemia, which is also called HBSS, sickle cell trait, it is called HBAS, hemoglobin sickle C disease HBSC, hemoglobin sickle beta thalassemia HBS beta thalassemia, hemoglobin S alpha thalassemia HBS alpha thalassemia. Now we learn about genetics and pathophysiology. The normal Hb molecule contains 2 alpha and 2 beta globin chain, and sickle mutation occurs in beta globin chain. It is a monogenic disorder due to the single base pair point mutation in beta globin gene resulting in substitution of amino acid valine for glutamic acid on chromosome 11. RBCs that contain HBS or HBS in combination with other abnormal B alleles when exposed to deoxygenated environment undergo polymerization and become rigid. These rigid RBCs are liable to hemolysis and also liable to increase adhesion and forming RBC clumping. This RBC blocks small blood vessels. This leads to vaso-occlusion, tissue ischemia, infection and hemolysis. Unlike normal RBCs, half-life is about 120 days. Sickle RBCs may survive just 10 to 20 days. High concentration of HBS and dehydration leads to repeated damage to RBC membrane and increased risk of further polymerization of HBS. This cycle of increased HBS, release of inflammatory mediators and free radicals leads to reperfusion injury to the tissue. The inheritance pattern of sickle cell disease is autosomal recessive. If both parents are carrier of this disease, then there are 25% chances that the child is affected with sickle cell anemia and having genotype of HBSS, and 50% chances that the child is carrier having a genotype of HBAS. Now we learn about the laboratory tests that are available for the diagnosis of sickle cell disease. They are CBC, retic count, peripheral blood smear examination, solubility and sickling test, HPLC, HB electrophoresis, isoelectric focusing, PCR, RFLP, DNA microarray, NGS, CVS, and DNA analysis. CBC is a primary test to characterize the different type of anemia. Patient with HBSS and HBS beta thalassemia usually present with hemolytic anemia where RBC count, hemoglobin and HCT are low and platelet and WBCs are high. MCV is usually elevated in sickle cell disease patient receiving hydroxyurea and MCV is low in sickle beta thalassemia patients. Reticulocyte count are increased with a degree of anemia caused by hemolysis, sequestration and bone marrow response. Peripheral blood smear. It examines the morphology of blood cells and evaluates the microscopic changes, and this provides the valuable information for diagnosis of different type of anemia. Peripheral blood smear shows elongated RBC with tapering ends that are sickle cells. Other findings are microcytic hypochromic RBCs in sickle thalassemia heterozygous patient, anisopoikilocytosis are seen, target cells and NRBCs are seen, polychromatic RBCs are also seen. Howell-Jolly bodies, they are the remnants of DNA seen in the RBC which are seen in the patient in whom the spleen has been removed and in patient with autosplenectomy. Pappenheimer bodies inside RBC are also seen. Neutrophilia and thrombocytosis are observed. Solubility test. It is a primary screening test. Solubility tests are mainly based on the polymerization of HBS in deoxygenated state. The principle is based on insolubility of HBS in presence of concentrated phosphate buffer, a hemolyzing agent, and the sodium dithionate. These agents crystallize HBS, precipitate cells, which refract light and cause solution turbidity. This test is easy to perform and inexpensive. The disadvantage is that it cannot distinguish between sickle cell trait and sickle cell anemia. It gives false negative result in certain conditions like in the newborn due to the high percentage of HbF. When sickle hemoglobin is less than 10% of total hemoglobin. In patients with sickle alpha thalassemia trait and in severe anemia. The test gives false positive results in case of high serum viscosity in erythrocytosis and with highly marked leukocytosis. The next test available is HB electrophoresis. This is also a screening test. It is a type of chromatography technique to identify hemoglobin variants. Different pH and mediums are used, either cellulose acetate electrophoresis at alkaline pH or citrate agar at acidic pH. The alkaline electrophoresis is a diagnostic tool that used to detect thalassemia and sickle cell anemia at pH 8.4. Hemolysate is prepared from RBCs and added to cellulose strip and run in the buffer at a constant voltage in electrophoresis chamber. As a result, different hemoglobin type with different net charges are separated into the various bands depending on their mobility. Alkaline electrophoresis can be affected by presence of large amount of hemoglobin F in newborns, which can dominate smaller bands like HbA2, HbH and Hb bars. Another technique is capillary electrophoresis. It separates the protein in an untreated fused silica column reliably. This method has 8 parallel fused silica columns where multiple samples can be analyzed. The reference range for HbA2 are adopted to be 2% to 3.2% and less than 0.8% for HbF. In presence of different hemoglobin variants, capillary zone electrophoresis is better than HPLC for quantifying HbA2 except in presence of HbC. Capillary electrophoresis is a first-line screening test for newborns and in adults. This table shows interpretation of various hemoglobin sickle variants. In hemoglobin SS, which is also called the sickle cell anemia, where HbS is more than 90%, HbF is less than 10%, HbA2 is less than 3.5%, and no HbA. In HbS-C, HbS and C are 50% of each, and no other bands are seen. In HbS beta thalassemia plus, HbS is more than 60%, hemoglobin F is less than 20%, hemoglobin A2 is more than 3.5%, and HbA is between 10 to 30%. And in sickle beta thalassemia 0, HbS is more than 80%, HbF is less than 20%, HbA2 is more than 3.5%, and no HbA is seen. Severe anemia seen in HbSS and Hb sickle beta 0 thalassemia. Mild to moderate anemia seen in HbSC and HbS beta plus thalassemia. Normocytic normochromic anemia is seen in HbSS, and in others we can see microcytic hypochromic anemia. HPLC is a chromatography technique. It detects the different type of hemoglobin based on the retention time and the shape of the peak. It can be used to detect and quantify HbF, HbA2, HbS, HbC, Hb bars and other hemoglobin variants. It can be used as a screening test for sickle cell disease. Now we learn about the genetic tests. First is PCR based technique. In this technique, the special enzymes are used to amplify specific parts of genetic material to millions of copies using specific primers. It can detect single gene or several genes in the single tube. PCR program involves denaturation, annealing, and elongation, which is repeated for 20 to 40 thermal cycles. After 40 cycles, target DNA and RNA sequence generated in multiple copies. The result can be detected by gel electrophoresis, sequencing, melting curve analysis, or monitoring change in fluorescence. The PCR-based technique called high-resolution melting analysis used in the mass screening of sickle cell disease genotypes. The curve is plotted where the temperature is on x-axis and the fluorescence is on y-axis. Another technique called amplification refractory mutation system. ARMS used in the prenatal diagnosis by detection of sickle cell mutation in the fetal sample. It can detect sickle cell mutation using two PCR primers. One primer is used for the normal allele and the other one used for the mutated allele. The primer is joined to complementary sequence and amplified, which in turn release the fluorescent label that determines the amount of the target. Other techniques available are restriction fragment length polymorphism, also called RFLP, DNA microarrays, and next generation sequencing. Let us discuss about the innovative technique for diagnosis and monitoring of sickle cell disease. First is image processing techniques. The blood cell disorder can be classified based on the different features like cell shape, central pallor, diameter, target flags, etc. These cells are classified based on the image features by using segmentation and artificial neural networks. The blood images are captured using camera connected to light microscope. Computer classifier is trained to classify cells in the photos. The disadvantage is that it cannot differentiate between the different type of sickle cell disease. The second is emerging flow cytometry. Imaging flow cytometry assay SIFCA and software algorithm is used to distinguish between sickle cell and the normal RBCs based on their morphology. The SIFCA is performed by diluting the peripheral blood sample, deoxygenating the cells by reducing oxygen to 2% for 2 hours, and then analyze it using the imaging flow cytometry. It can assess sickling tendency in SCA patient to identify the severity of disease and drug monitoring. The other technique is microfluidic flow cytometry based on electrical impedance and spectroscopy. The disadvantage is they cannot distinguish between sickle cell trait and sickle cell anemia. The third is mechanical differentiation of sickle cell. They can be used to monitor hydroxyurea response in sickle cell disease. The technologies used in this type of method are optical tweezer technology, amplitude modulated electrode deformation in microfluidic method, and analysis of cell membrane fluctuations. They can't distinguish between different type of sickle cell disease and can't indicate the severity of disease. Fourth is lateral flow immunoassay. The test used polyclonal antibodies on the lateral flow chromatographic immunoassay against HBS, HBC and HBA to detect different type of sickle cell disease qualitatively. Antibodies are attached on the test strip. Sample migrate in the absorbent pads where antibody conjugated to nanoparticle binds to hemoglobin and both migrate to a test strip. Hemoglobin bind to corresponding antibodies and form blue line. It is easy and quick to perform. High HbF percentage does not interfere with the result. Some of the limitations of this test are misinterpretation of result due to visual reading, cross-reactivity of polyclonal antibodies, and false positive results. Next is density-based separation. It detects sickle RBCs using aqueous multiphase system based on cell density measurement. The dense sickle cell can be distinguished from the normal cells by two-phase AMPS system. The test requires 5 microliter of blood sample which is mixed in the capillary tube with aqueous polymeric solution. Upon 10 minutes of centrifugation, the dense RBC precipitate and form a layer in the bottom of the tube indicating sickle cell disease. This test is affected by high HbF percentage and cannot distinguish between sickle cell trait and sickle cell anemia. Next is paper-based Hb solubility test. In this test, the drop of blood sample is mixed with hemoglobin solubility agent with a ratio of 1:10. Then the mixture is placed on the chromatography paper followed by staining. The different stain blood pattern form based on the hemoglobin present. This test is affected by high HbF percentage and cannot distinguish between HbSC and HbAs. Next is sensor-based techniques. Methods available are fluorescent-based optofluidic resonators, sensor based on electrical impedance signal, quartz crystals, and genosensor. Seventh is pyrosequencing technique. It has been used to identify different type of homozygous or heterozygous sickle cell disease. It provides accurate diagnosis for sickle cell disease and used in neonatal screening. Clinical features observed in the sickle cell disease are vaso-occlusive crisis, acute chest syndromes, infection, pulmonary hypertension, cerebrovascular accidents, pulmonary embolism, renal complication, eye complication, splenic sequestration, priapism, cholelithiasis, osteonecrosis, aplastic crisis, etc. Fever. Fever in the children is a criteria for admission. Investigation required are CBC, renal liver bone profile, blood culture, urine and chest X-ray if indicated, throat swab, and virology if indicated. Acute splenic sequestration and erythroid aplasia are commonly associated with fever. The treatment is IV ceftriaxone. If chest symptoms are present, add microlide antibiotics also. Infection. The second most common cause of death in the children with sickle cell disease is a strep pneumoniae sepsis. Important preventive measure is vaccination and prophylactic penicillin. 23-valent strep pneumoniae polysaccharide vaccine to all children with sickle cell disease at 24 months of the age and adults with sickle cell disease is recommended. Prophylactic penicillin should be given to all newborn with sickle cell disease. Conjugated influenza vaccine is also recommended. Next is vaso-occlusive crisis, pain crisis. Hallmark acute manifestation of sickle cell disease is sudden onset of discomfort and pain. Any bone can be affected, hands and feet in the younger children, also called the dactylitis. The primary goal of management is to achieve prompt and safe pain control. Oral analgesic can be used to manage most mild to moderate pain episodes at home. Non-medical therapies such as hot bath, shower, massage, distraction and relaxation techniques also can be used to relieve the pain. First dose of appropriate potent analgesic must be administered within 30 minutes of the patient presenting in the emergency. The drug of choices are NSAIDs and acetaminophen. Codeine, oxycodone, hydroxycodone are also used for the moderate pain. Other drugs are morphine sulfate, hydromorphine. Other morphine equivalent opioids include oxymorphine, levorphanol, meperidine, fentanyl and methadone. Next is acute splenic sequestration crisis. ASSC is caused by the intrasplenic trapping of RBCs, which causes a precipitous fall in hemoglobin level and potential for hypoxic and hypovolemic shock. It is defined as an acute enlargement of the spleen with a drop in hemoglobin level at least 2 gram per dl from the baseline. Splenic measurement should be done and urgent blood transfusion is required. If repeated episodes occur, elective splenectomy is advised. The next is acute chest syndromes, ACS. It is the second most common cause of hospitalization. It is characterized by intrapulmonary ischemia and infection, systemic hypoxia, and pulmonary infiltrate in the chest X-ray. Antibiotic of choice are cephalosporins and macrolide. Pain relief should be adequate to prevent hypoventilation. Keep O2 more than 95% and supplement O2. IV fluids required for the hydration. Simple blood transfusion and exchange transfusion required according to the patient's condition. ICU admission and supported ventilation also required if condition worsen. General consideration. Practice guidelines are pneumococcal vaccine and penicillin prophylaxis prevent pneumococcal infection and sepsis in the children. Folic acid supplements are essential. In surgical setting, simple transfusion to increase Hb levels to 10 gram per dl are recommended. Transfusion to maintain HCT more than 36% does not reduce complication of pregnancy. Transfusion for reduced HbS less than 30% prevent stroke in children. Hydroxyurea decrease crisis in the severe sickle cell disease. Pain episode may increase during pregnancy, but the treatment is same as hydration, oxygen and analgesics. The narcotic use does not affect the fetus health, but if large dose of opioids are needed late in pregnancy, the newborn may require opioid weaning. If the patient is on hydroxyurea and is planning or trying to conceive, the drug should be stopped immediately. Specific therapies for sickle cell disease. First is hydrocarbamide or hydroxyurea therapy. It acts by following mechanism: increase production of HbF, decrease neutrophil count and reticulocytes, decrease adhesiveness and improve rheology of circulating neutrophil and reticulocytes, reduced hemolysis through improved red cell hydration, macrocytosis and reduced intracellular sickling, nitric oxide release with potential local vasodilatation and improved vascular response. The second is chronic blood transfusion. Third is hematopoietic stem cell transplant treatment. And fourth is gene therapy. Three main model working in the India as a screening program for sickle cell disease are village based model, comprehensive care model and newborn screening model. The examples of the tribe where sickle cell disease is more prevalent. In central India, Gonds and Bhils. In Maharashtra, Bhils, Madhyas, Pavaras, Pradhans and Otkars. In Gujarat, Dodia, Dubla, Gamit, Naika, Chaudhary, Rohit, Vasawa, Kukana. Certain tribes, Chaudhary, Gamit, Rohit, Vasawa and Kukana have shown both high prevalence of HbS as well as beta thalassemia trait. Concomitant G6PD deficiency worsen anemia and increase blood transfusion requirement in the infancy and early childhood up to 2 years of age. Summary: sickle cell anemia is systemic disorder that affects the entire body. Most hemoglobin variants can be identified by RBC indices, peripheral blood smear study, HB electrophoresis, and family study. Genetic tests are recommended to validate borderline cases and detect novel variants. All specialties need to be involved in managing the patient with sickle cell anemia. These are the references for this video. Thank you.